So we're now going to move on to welcoming Professor Paul Klenerman to speak to us. Paul is trained in medicine at Cambridge and Oxford, and then specialised in infectious diseases. After a PhD working in HIV with Professor Andrew McMichael and Rodney Phillips in Oxford, he worked on LCMV in Zurich with Rolf Zinkernagel and Hans Hengartner. He had Wellcome funding to work on T cells and virus infections since then, and has been looking at T cell responses to CMV and to HCV, including the development of vaccines. This includes studies of intrahepatic T cells, which led on to analysing the abundant unconventional T cell populations in those individuals. In the COVID-19 response, he helped to integrate immunology studies from across Oxford and established a large collaboration called PITCH, focusing on T cell responses in UK healthcare workers. He holds a chair at Oxford, working at the Translational Gastroenterology Unit and at the Medawar Building in Pathogen Research. So thank you very much, Paul, for speaking to us today. And the title of your talk is PITCH, COVID-19 Immunity Studies in the UK Healthcare Worker Cohort. So thank you very much.
Great, thanks for the intro. I'm presenting on behalf of a lot of other people. PITCH is quite a big consortium across the UK, which hopefully you can see if I can just forward the slide. So yeah, we set it up in 2020 because everybody recognized it would be useful to know something about T cells. And it's proven to be the case. So we had sort of individual healthcare worker cohorts that were set up in different places, and essentially we either created new ones that for example in Newcastle, or merged them so that we could all work together. And there's a much bigger study called SIREN, which you might well have heard of, which is studying UK health workers. It's about sort of 10 times the size, but it's not really set up to do any T cell work. So it was a smaller, but we've recruited thousands of healthcare workers to study their cellular immune responses. So it's reasonably sized. And the good thing about being linked in with SIREN is that they're collecting data on kind of in the cohort on infection in a prospective way. So that's given us some kind of special insights. So I'm just going to show you a couple of bits of data, and everything I show you today is actually already published. We have got more stuff coming out, but it's not really quite ready to present. So I thought it was sort of more sensible to just dig a bit deeper into what we've done. So the first thing we obviously did, like all the other groups you've heard today, was just set up some assays. And we set up a range of different T cell assays and kind of looked at what they told us, comparing proliferation and AIM and ELISpot and things like that. And we essentially tend to use ELISpots just because they're functional and easy, and actually have a very low background to the pre-existing immunity that you might get from circulating coronas. This paper from Adriano was looking at sort of what happened after the acute infection, and merging the data from T cells and other studies of antibodies, as we've sort of done all the way through. And then at the time, of course, it was very important for the Oxford vaccine developers to have some comparators from natural infection, just to see where essentially the T cells and antibodies lay. And so we provided a range of controls for that. And then these are other things that sort of spun out of it, which weren't actually what we intended to do at all. But Gavin Screeton in Oxford then set up some monoclonal antibody studies based on infections with the various waves as they come through. So each time a wave has come through, he's created more monoclonals, more structural biology, and really helped define the role of individual mutants in escaping antibodies and changing the affinity of the ACE2 binding of these RBDs. So if anybody's really interested in the fine details of that, there's literally one per mutant. And there's this, which again, I'm not going to go into, but it was a kind of massive study that we put together at Oxford, again, with healthcare workers incorporated, to try and just compare as many phenotypic features, genotypic features, and essentially a multi-omic study of COVID as you go from mild to very severe disease, and then mapping that against flu and sepsis. This is just an example of sort of just one of the outputs, which was the integrated genomic data, which you can dilute down to, or concentrate down rather, to two principal components. and severity is sort of the first principal component here. And actually, T cells do play a role in driving that first principal component, but it's actually the unconventional T cells, such as mate cells, that are the key drivers of that. But if you're interested in that, you probably need to delve into this, which is all the data is freely available if people want to mine that. So I'm going to talk just briefly about what some of the T cell work we've done with pitch. So the first thing that came out, and the reason I sort of reiterate it, was looking at what prior infection does. And the reason I thought it was worth just reminding people is it's still having some long-term impact on both immunogenicity and also protection over the longer period, despite, you know, the fantastic boost that you get from the vaccines. So this is just the antibodies. Everybody be familiar with these sorts of ELISAs. So in a naive person, very low, and then after a dose, a decent boost. So this is all Pfizer as it came out in early 2021 or late 2020. Pre, you're kind of about here already, and you get a good boost. So nothing too surprising, other than that pre and an extra dose is actually pretty substantial compared to even 2 doses naive. So that I think has been reiterated by multiple groups, but it is a striking feature that the prior infection not only has this sort of immediate effect, but has this sort of carry through that we're now starting to see later on as things have evolved over many months. And this is basically the same data for T cells. So one of the features that we can, I mean, this is not, I don't think it's a technical issue, it's just the biology. I mean, there's a huge range of responses to these things. And often people put them on a log scale, which maybe minimizes that. But even in healthy donors, I mean, and this cohort of healthcare workers is very largely kind of healthy, dominantly female, as you'll see in a minute, and essentially kind of otherwise minimal health problems. So you get a little bit of a T cell response after 1 dose, which again, it was kind of new at the time. If you've got previous infection, you can boost that, you know, some people pretty substantially. And the people with prior infection have got responses to N and M, which are quite detectable but don't shift. If you're naive, we never really find much of a response to those with an ELISpot, although you can find responses if you go digging. So I thought I'd spend most of the rest of the talk just on this paper, which came out last year and which has sort of formed the basis for the follow-up studies as well. So we were able to, because we could combine resources, we were able to look at T cells in nearly 600 people. Really the question that we were addressing here, which is a kind of UK speciality, is what happens if you extend the dosing interval? So it's quite a nice kind of question to address, because if you weren't in the UK, this might have passed you by, but there was quite an issue at the time, because in January, when they'd started the rollout, especially to healthcare workers in the first kind of wave of vaccines. And then just as they started to roll it out, the government bodies and the chief medical officer decided it was a better idea to give more people 1 dose, and then you get more people onto the kind of on the track, basically, and then leave a bit longer before you gave them the 2nd dose. It just gave more coverage initially, and that was massively controversial because there wasn't any data from the trials about giving long dosing intervals, and the companies thought this was probably not a good idea, and some health professionals thought it was a terrible idea. But actually, this immunologically, it kind of seemed perfectly reasonable. So there was sort of equipoise anyway. But fundamentally, because we were running this prospective study in the healthcare workers, we just absorbed that, and it wasn't perfectly balanced, but we did have people in both arms, relatively few in the short arm and a lot in the longer arm. But what's interesting is that if you give 1 dose, and this is looking at naive individuals, and this is again from our parent study, the SIREN, is in that first period after your first dose and before your 2nd dose, which is about 10 or 12 weeks, you've actually got quite good protection, and if anything, it gets better during this period. It certainly isn't something that sort of comes and goes. That's after the 2nd dose, where at the time there wasn't such good data, although now we know after a 2nd dose it's pretty good, or they might wane a little bit later into the follow-up. So that was curious, actually, especially, whoops, as I'll show you, if you look at the immunogenicity. So this is a setup, so we were able to study patients. We've actually got quite a lot of data, which I just don't have time to really show today, around the very early response, so the day one after the prime and boost, and the innate responses and how they relate to the adaptive responses, but we'll have to follow up on that. But the key things are sort of a week, but critically 4 weeks after the second dose, and that's the same, essentially the same time point, 4 weeks after the second dose, but with this much longer interval. And of course, there's the chaos of rolling this out, where some people got their second dose somewhere in the middle, and they didn't, and not everything went exactly to plan, but it was certainly extended compared to the 3 to 4 week interval. This is our group, and this is the group that we routinely get when we do these studies. So they tend, if you just look at the kind of denominators, that they sort of tend to be female dominated, as that reflects the workforce really, with a kind of mean age of about 40 or so. That's the kind of person that we managed to capture. But the range is pretty decent, and we were able, and I won't show you this, to look at co-correlates of all these things. So age, sex, BMI, ethnicity, as much as we could, but nothing made a huge difference, to be honest. And yeah, and we know, of course, their previous infection status, either by self-reporting or by serostatus, which is, I think, what we opted for in the end, just for clarity. So this is quite interesting. I mean, this is fairly old now, so you just have to cast your mind back to what was happening sort of this time last year. But in that period between the doses, you do actually lose, despite I just showed you, you're quite well protected. You don't actually have particularly good newts. Some people have none at all, and they wane over that time. That's against the strain you're effectively vaccinated against, and but they're beautifully boosted. If you start to look at the other strains, including alpha, which was prevalent at the time, it's much worse. These other strains available, but I mean they're not quite so relevant to the challenge that the patients were getting, but you don't have that great protection against these. So if those strains had been circulating, you might have seen something slightly different, but we were in the middle of the alpha wave. So I would say that just because the antibodies are waning, and in some cases not very good, but you get pretty good protection, you wouldn't reach for neutralizing antibodies as your correlate protection here, despite their kind of obvious role in most studies. If you look at binding antibodies, you start to get these really interesting features. So the people that, this is not looking at the interval between doses, is looking at the interval after the second dose. You get quite a nice finding, which is that the people who are naive have a clearly better response. It's not huge, but it was easily measurable at this scale, using just ELISAs for the total spike, or RBD. The N, which reflects a previous infection, is low in the naive cohort, although something was going on here which we've never really figured out. Is possibly a little bit of exposure patterning. And again, just to reiterate my point, if you've had previous infection, you've still got this carry through of an additional effect, but it's still quite a strong antibody response all the way through. And the interval didn't really seem to make much of a difference in those people you've sort of maxed out. This is what happens with the newts then. Now, so again, I think most people studies with all these ELISAs and so forth, that the newts are kind of roughly paralleling them. And again, and most of the variants that we were studying with the help of Gavin Screeton's group were knocked down, and nothing quite as dramatic as Omicron, but they're all having their own effect. But you can see again that the longer interval does actually improve your newts to a quite easily measurable degree, and especially once you're starting to lose them as you go across to these variants of concern, the kind of impact is a little bit more striking. So that's one clear result, and underpinning that, there are clearly B cell memory responses laid down that we can detect with an ELISpot. And again, they seem to be slightly better with the longer dosing interval. But the differences are probably, these are smallish numbers, but we were asked to have a look. But you clearly do lay down B cell memory, even though your newts and so forth are relatively low in that interdose interval. Then if you start to look at the T cells, you get the opposite result, which is again a kind of curiosity that we are not sure we'd anticipated. And I think we might have some mechanistic explanations for this, but it's still a little way off. But just in terms of the phenotype, the short interval is actually better for your T cells in terms of just gamma ELISpots, and that's pretty clear. And again, it's, you know, the impact of previous infection is still really important. This is your M&N, which are not really there to any proper extent in naives, and not really affected by vaccination. So that's a kind of basic response. And if you break it down a bit by doing some ICS, which was all done we did this in one lab. We tended to kind of devolve the ELISpots and concentrate the ICS. So then if again, there's the naive folk, there's clearly a kind of advantage in the long in generating IL-2 secreting spike specific T cells. So, I mean, these are reasonable numbers and the assay is reasonably good. So I would say that's a kind of believable difference. The differences in gamma are much less clear for the CD4s. It seemed to be more evident for IL-2. This is just kind of the same data really kind of spread out a little bit. But I think that was really the kind of striking result. But so it's a bit more CD4 skewed and a lot more IL-2 skewed. And if you look at the total functionality, you can see if you look at sort of triple secreting cytokines. So it wasn't like the most elaborate ICS that you could do, but it was pretty good workhorse one at this scale. You can see a clear result there. So you do shift the dial a little bit with the T cells in the opposite direction from the antibodies. So I thought I'd just stop there. I think we're kind of out of time. So firstly, the extending the dose is perfectly protective, and actually the antibody levels are higher. And that means antibodies of how you really measure them. The extended regime does seem to kind of skew the T cell response towards a helper response expressing IL-2. And there is waning, and I would say, just to kind of summarize what we've seen in the without showing you the data in the longer term follow-up, is that you obviously do get waning of the antibodies over that longer period, but the T cells and now we've incorporated AZ data are all relatively well maintained over the longer term period with again a kind of clear long-term impact of the prior infection. So that is that. I should thank everybody, which is a large list of people. So Susie's been very key to this in Oxford, and she sort of marshaled a lot of these troops together. All the clinical staff have been brilliant, including the participants. Alexi has sort of held it all together, trying to herd all these different groups into one cohort. And I'll stop and take questions.
Great, thank you very much indeed, Paul. Really appreciate that. Yeah, so please raise a hand or type a question into a chat. That would be great to hear from you if you want to ask Paul any questions at all about the pitch study and the data that he's been sharing. Yep, we have a question here. So Moderna and Pfizer are pushing for a second booster fourth dose. What's your thought on this based on T cell responses that you see?
Well, we're just analysing the third dose, and I don't know for the average person. I mean, this all comes down to what you're trying to protect against, and also comes down to kind of vaccine fairness. So, I mean, obviously the answer is you should get more people their first and second dose and start giving people who are already quite well protected their third and fourth dose, with the exception of, you know, what Marcus has been describing, some of those immunosuppressed individuals who seem to benefit. We've also got the same sorts of data where people who haven't made any response to 1 and 2 are suddenly picking up with 3 and possibly 4. So I don't know. It's really, really interesting what kind of memory is being formed. But I just from a kind of immunological perspective, it looks to be fine, robust memory. So I think there'll be some subtleties there, but I don't think the RNA vaccines are kind of breaking any rules. I think if you want to maintain really good mucosal immunity and incredibly high levels of neutralizing antibodies and sort of incredibly high level of protection just by vaccines alone, you probably have to keep boosting people up to some max. But if there's an ongoing infection, which, as I've said many times here, that sort of changes the game a bit. And if those infections are not causing severe disease, then you probably wouldn't be forced to do that.
Great. Thank you very much, Paul.